Okay. Many of us fail to realize the intricate mechanics involved in the structure and working of the human body. It is only when tremendous changes take place in the body that we learn to appreciate its capabilities. To our respected judges, and to the faculty of the Department of Medical Physiology, and to our future PLM physicians, a pleasant morning. On behalf of Group 1, Section 1A, I am Casey Ilagan, and I present to you a case of cardiogenic shock secondary to right-sided heart failure, secondary to massive pulmonary embolism, a sequelae of expiratory laparotomy. A 48-year-old female patient who worked as an administrative assistant in a local college was rushed by the paramedics one night to the emergency room due to cardiac arrest. The initial vital signs were as follows. The pertinent general survey included the following. There was cyanosis of the peripheries. The pupils were sluggishly reactive to light and had no spontaneous movement, and the patient's left lower leg was slightly edematous to the level of the mid-calves. On history taking, it was learned that a few weeks ago, the patient was hospitalized for 7 days as she underwent an expiratory laparotomy because of a phlemonous mass with purulent fluid in her abdomen. As the patient gradually recovered 2 weeks after she was discharged, she noted progressive swelling and pain in her left lower leg. The leg pain worsened acutely one morning. Because of this and the slight difficulty of breathing without chest discomfort the patient felt, she sought consult. There were no other atypical manifestations except for her slightly edematous left leg, graded as 1+. The area of swelling is markedly tender to palpation. The leg looks slightly pale with diminished but palpable pulses. In review of history, the patient's mother had phlebitis. The attending physician gave the patient ibuprofen and started her on 80 mg aspirin to be taken daily. A few days after, the patient complained of intermittent, mild right-sided chest pain, which originated from her right shoulder blade. The pain recurred with deep inspiration and when lying down. Attributing the pain to her post-operative wound, the patient dismissed the symptom. On the evening prior to being rushed to the emergency room, the patient was apparently relaxed, watching TV according to her husband. When she stood up, she suddenly experienced severe chest pain and shortness of breath. The patient collapsed with synchronous jerking of her arms and legs. When the paramedics arrived, the patient was conscious, in severe chest pain and somewhat combative. She rapidly became unresponsive, pulseless, and with agonized respirations. Intubation was done. 2 doses of epinephrine and 1 dose of atropine were given intravenously. CPR was rendered on the way to the hospital. Back to the scene in the emergency room, the patient remained unresponsive. Despite placing her on ventilatory support at FiO2 100%, her O2 sat remained 76 to 84% only. Several lab exams and diagnostic procedures were ordered for management. Within a few minutes upon arrival, the patient had her second cardiac arrest. 2 doses of epinephrine, 1 vial of D5050, and 1 ampoule of sodium bicarbonate were given. After 5 minutes, she was revived. Dopamine drip was started to maintain her SBP at 130 to 140 millimeters mercury. Highlighted here are the pathologic findings from her laboratory and diagnostic evaluation. Let us now try to identify the reasons why the patient had cardiac arrest. In our history taking, we learned that the patient underwent a major surgery. Days after, she complained of a progressive left leg swelling and pain. At this point, we suspected a case of deep vein thrombosis. This impression may be analyzed based on the classic virtuous triad in DVT. Stasis, endothelium injury, and hypercoagulability are the combined factors in describing the etiology of DVT. Prolonged bed rest from her major surgery may have contributed to blood stasis in the patient's case. Vessel wall injuries from abdominal surgeries are common. We consider that the patient may have a hypercoagulable state because of the following predisposing factors: her gender, the effects of estrogen and blood viscosity, inflammatory mediators that were released and activated, and the clotting factors that were included in the repair mechanisms. Utilizing Bell's clinical decision rules to evaluate the probability of DVT, the patient scored 5. This reflected a high likelihood to develop DVT. With the analysis of virtuous triad and the computed Wells scoring, DVT was considered the main instigating factor in this clinical case. The activation of the extrinsic coagulation pathway initiated clot formation in the patient's left leg. A cascade of inflammatory and clotting formation mechanisms eventually led to thrombus formation. The metabolism of arachidonic acid and the release of substances such as histamine, bradykinin, prostaglandin, and cytokines generated the signs and symptoms of inflammation and pain. As the patient gradually recovered from her surgery, activities of daily living were also eventually resumed. This meant an increase in the activity of the muscles during movement. When the thrombus was dislodged from the deep vein, it flowed to the larger blood vessels until it reached the heart via the IVC. In several instances, an embolus adhered to the pulmonary arteries. Considering that it was in the pulmonary artery the embolus adhered, the blockage caused an increase in the pulmonary vascular resistance, thereby altering the pulmonary arterial pressure. The rise in PAP led to pulmonary hypertension. As the pressure built, the right ventricle had to double its pumping ability to preserve the cardiac output. That was why, when the 2D echo was ordered twice after cardiac arrest, the results revealed dilatation and hypokinesis of the right ventricle, poor right ventricular contraction, and moderate tricuspid regurgitation in the right atrium. The impaired blood flow caused a vasoconstriction reflex. The blood shifted to non-obstructive areas, which increased the capillary hydrostatic pressure. Transudation of fluid transpired when both capillary pressure and hydrostatic pressure escalated. The right lung became consolidated, most prominently in the upper lung lobe as seen in the chest radiograph. The hypertrophied right side of the heart led to interventricular dependence and left diastolic impairment, which affected the ventricular filling during diastole. Due to increase in right atrial pressure and mean systolic filling pressure, a damming effect decreased the venous return to the heart. All these led to a decrease in stroke volume. The decrease in cardiac output diminished subendocardial perfusion that limited the myocardial oxygen supply. As the heart reached its pumping limits, its contraction weakened. Ultimately, these pathologic turn of events resulted to cardiac arrest, hence transient cessation of systemic blood supply. On a cellular level, the impaired cardiac output inadequately delivered oxygen to the cells. A consequent alteration in metabolism and a shift in the oxygen-hemoglobin dissociation curve explain the manifestations of cyanosis, hypothermia, persistently low oxygen saturation, and partly of the respiratory acidosis reflected in the patient's ABG. The transient global cerebral hypoperfusion was reflected in the changes in the pupillary reflexes, gag reflex, and synchronous jerking of the arms and legs when she collapsed. Neuroendocrine responses to decreased cardiac output stimulated the release of hormones from the pituitary gland and adrenals. The catecholamines played a very crucial role to the stress response. The hormones acted synergistically to increase blood glucose. Moreover, the doses of epinephrine administered during cardiac arrest contributed to an increase in plasma glucose. To compensate for the impaired cardiac output, the heart had to pump harder. The strain and enlargement of the muscles in the right ventricle, consequent stretch of the Purkinje fibers, and the compromised coronary supply altered the arrival of the electrical impulses. This was reflected in the ECG tracing of the patient. Renal response to decreased cardiac output activated the renin-angiotensin-aldosterone system. The affected renal perfusion led to an insult in the renal tissues. Acute kidney injury occurred in the patient after she was revived and transferred to the coronary care unit. Decrease in the renal functioning caused a diminished renal output and accumulation of creatinine and BUN. Positive feedback loops contributed to the vicious cycle of cardiac arrest. For this reason, the patient had to be administered with vasopressor agents such as norepinephrine and dopamine to maintain adequate blood pressure and sodium bicarbonate drip to counteract the acidosis of the body. Now that we have understood the pathophysiologic mechanisms, let us go back to our patient in the ER. After the patient's condition was stabilized by pharmacologic mechanisms and ventilatory support, she was transferred to the coronary care unit. In here, she received IV bolus of recombinant tissue plasminogen activator and heparin infusion. Hours after, her condition and vital signs improved. She was extubated later that day. Her mental status improved and she was able to follow commands and talk to their family. On her 4th hospital day, however, warfarin therapy was initiated. 4 days after initiation of warfarin therapy, she had 2 episodes of epistaxis. On the 10th hospital day post-arrest, she had tonic-clonic seizure. CT scan in her head showed small left frontal and cerebellar hemorrhages. Now, how did the patient develop those hemorrhages? Even though aspirin, heparin, TPA, and warfarin have different actions, all of them were used for anticoagulation in the case. The interplay of these medications predisposed the patient to coagulation disorders and eventually led to increased bleeding tendency. The epistaxis was an early manifestation. The clonic seizure was an alteration in the action potential. The phenytoin drug was started and no further seizures occurred. The patient was discharged to her rehabilitation facility on the 24th hospital day. In her follow-up evaluation, she had residual right-sided weakness from her intracerebral hemorrhages. This gradually improved and she returned to work 5 months after the cardiac arrest. 11 months after discharge, the patient resumed her normal ADS. Ladies and gentlemen, once again, a case of cardiogenic shock secondary to right-sided heart failure, secondary to massive pulmonary embolism, and sequelae of expiratory laparotomy. Thank you very much.